Marks, and I'm an analyst with the ADRC Bureau team at the California Department of Aging. From the ADRC Bureau, please welcome Sandra De Silva, Janice Ho, Sarah Conrad, Amanda Price, and our newest team member, Patricia Leal. From the Person-Centered Navigation Branch, please welcome Wilson Tam and Hetty Lim. Next slide, please. Some logistics to start. If you're dialing in, please dial *9 to raise your hand and *6 to unmute. You may also use the raise hand feature and ask to unmute, and we'll be sure to answer your questions. The live transcript button is on the Zoom toolbar for closed captioning. We are recording this roundtable, and the recording will be available on the ADRC Library tab on the ADRC Partners and Providers website. If you're having technical issues with Zoom, please email us at adrc@aging.ca.gov. Please use the chat feature to communicate questions or comments. We will summarize these throughout the roundtable hour. Please start introducing yourself in chat. Who are you and where are you located? Next slide, please. Today's agenda will include 2 topics, if time permits. First, the ADRC Bureau is pleased to welcome special guests from the Lewin Group. They will speak about Medicaid administrative claiming and ADRCs. And again, if time permits, for the remainder of the time, we will have an open discussion about California's ADRC Infrastructure Grant Program. Please be ready to share the creative ways that your ADRC has utilized infrastructure grant funds to assist consumers in navigating long-term services and supports. Next slide, please. Now, let's turn to the discussion of developing the Medicaid Administrative Claiming Program that ADRCs will be able to take advantage of. Please welcome Kristen Vangeloff and Christina Neal Bowen from the Lewin Group. Kristen currently leads the ACL Long-Term Services and Supports Technical Assistance Contract with a focus on supporting states and local entities on developing robust governance, public outreach, person-centered practices, and streamlined eligibility to public programs. Prior to working with the Lewin Group, Kristen spent 8 years at a community-based organization serving populations at risk of infectious disease in rural Virginia. Also, please welcome Christina Neal Bowen. Christina is a change facilitator with over 25 years of experience assisting older adults, individuals with disabilities, and their caregivers to access services and supports. Additionally, Christina advises states, the federal government, and foundations on aging and disability policy with a focus on systems of access. And for the past 20 years, Christina has supported ACL and CMS in implementing the ADRC No Wrong Door systems for older adults, individuals with disabilities, and their caregivers. Christina and Kristen, welcome. Next slide, please.
Thanks so much, Allison, for the warm welcome, and good to see some familiar names in chat here. We've been having some conversations with local ADRC sites, so it's nice to see folks on the line. We're just going to spend a little bit of time with you today going through, if you want to go to the next slide, sort of 3 chunks of information. So first, we're going to give a little overview about Medicaid administrative claiming. That's what the MAC acronym stands for. And then we're going to talk a little bit about some of the state successes with MAC. So some examples of states that have recently implemented this in their own states for their no wrong door systems. And then finally, Kristen's going to go over some time tracking scenarios to sort of bring the content to life a little bit and try to put it in the context of activities that you may be doing on a daily basis. So if you go to the next slide, we can jump right in. I'd love to see your thoughts in chat. If you could put into the chat one question that you have about Medicaid administrative claiming. Maybe you participated in the time study, or maybe you didn't and you just have some questions, but this will really help us as we move through the presentation, trying to tailor to what your questions might be. So one question about Medicaid administrative claiming. If you could do that in the chat, that would be great. Great to see a bunch of different counties represented here in the chat already. We're really learning our California geography through this project, so this is great. All right, so enter those questions in the chat. If you go to the next slide, I want to just spend a little bit of time talking about some of the benefits of Medicaid administrative claiming for no wrong door systems. So I've really narrowed this down to 4 big ones that I think are really important. And the first one is that the Medicaid administrative claiming is 50% federal money and 50% other money. So it really stretches any state allocations or local support that you get. So if you're going to your legislature to ask for money for the no wrong door system, if you're claiming, you can say, please give us this money, and it will be matched by the federal government. So I think that's one really big benefit. The second one is that you're probably doing a lot of this already. So you're probably really helping people understand Medicaid, helping people apply for Medicaid. So it makes sense to get reimbursed for things that you're already doing. And so the other thing is that it's not like a Medicaid service dollar. It doesn't work that way. It's not a grant or a payment per service per se. So it's once you set up Medicaid administrative claiming, it's there for good, right? So you don't have to reapply and write a grant and say all the great things that you're doing to keep the money flowing. It's just in the infrastructure in your state. So that's how it's different from a grant. And then finally, there aren't any strings attached to the money that you might get reimbursed. So there's nothing like from the federal government that says you must spend this on, a certain aspect of your organization. And we're going to see in some of the subsequent slides how states are using the reimbursements and what they're using it for. So you can see the variety in that. So if you go to the next slide, and I don't see, okay, do I see any questions coming in yet? Let me see. Okay, so just a baseline knowledge. Yeah, hopefully we'll give you that today. All right, so here's some of the system's functions that are eligible for claiming. And if you went through the time study, then this is like kind of a repeat for you and you could be giving this presentation, but just to walk through it. So the first one is outreach and consumer education. And this has to do with any time that you're talking about the Medicaid program. And this could be with an individual family or an individual or their caregiver. If you're explaining Medicaid to them, letting them know how it works, letting them know what the eligibility criteria are. Or it could apply to if you're at a health fair and you're passing out some literature about Medicaid. So a portion of your time could be eligible for claiming. This can also apply to your intake or your application assistance. So when you're helping someone get their paperwork in order for Medicaid, or actually sitting down with someone helping them fill out an application or connecting them. all of that kind of thing. Continuous quality improvement has to do with, this could be a supervisor's time, helping to keep track of the time study, or like looking at the people, their staff's time study, and seeing and doing a quality review check to see how that's looking. This could also apply to the state level staff, looking at their procedures and their policies, and that also gets into program planning and training. So anytime that you might be doing any coordination with your local eligibility offices, or thinking about how to streamline the process, having meetings about that, that is all claimable. Person-centered counseling, when you're talking with people about Medicaid and helping them get connected to services, that is also claimable. And finally, we want to kind of stress this last point, that when you're talking with people and you're helping them get connected to Medicaid, you may be also diverting them from premature institutionalization or unnecessary institutionalization by setting them up with community supports. And that has also been part of the package that states have submitted to CMS for approval around Medicaid claiming. If you go to the next slide, we're going to talk a little bit about some of the other states and what successes they've seen with claiming. So if you go to the next slide, please, we'll start with Nebraska. So on this slide, Nebraska recently got, I think probably within the last couple of years, got approved for Medicaid administrative claiming for the no-run-door system. And they have a lot of partners. So they have some Centers for Independent Living, and the Brain Injury Alliance is one of their disability partners that has been involved in claiming. And these specific bullet points here are from that organization, like in their own words, like this is what they said. So we thought that would be interesting to show you. And on the right-hand side, there's the Brain Injury Alliance logo, which is a person's head and a sun on their head. So one of the things they said is, what? We don't bill Medicaid? So they were sort of surprised that they were doing these activities. Kind of goes back to that other slide, that you're doing these activities, but you're not getting reimbursed for them. Initially, they were scared about the time studies. But then they got the hang of it and they were okay with those. Same with the cost pool spreadsheet. Like once they really understood it, it wasn't that bad. And they refer to Medicaid administrative claiming as a pot of gold, and that they say the MAC funds are life-changing. And I have heard their executive director speak, and they really think they're going to be able to hire 2 new staff since they've been participating in Medicaid administrative claiming the last couple of years. So it's been really big for them. One of their things is they don't have a lot of federal funding, so they do have a lot of matching funds. So one thing about Medicaid administrative claiming is the funds that you have to match cannot be federal. So this has been a real gain for this disability partner in Nebraska. And the next slide shows you sort of what the deal is with their organization. They have about 8 staff participating in the time study. And you can see that the amount they've drawn down is, over the past year, $310,000. And they've done a couple of different things with the training. They've with the money, they've done staff training, strategic planning, upgrades to their database, and marketing and outreach. So they've really kind of put the funds in different places. And as I mentioned on the other slide, they are thinking about possibly adding more staff as their reimbursement rates just continue to go up. Next slide, please. And this is just kind of an overview of Nebraska. On the right-hand side is their ADRC logo for the state, which is the shape of their state with ADRC in the middle and their toll-free number. And so they're, upwards their claiming rate. That means like the amount of time that they're spending on a daily basis is almost up to 80% for some of their partners. And they do use a random moment time tracking methodology. They reported about 2.1 million in fiscal year 2022 across the state. And they have about 140 staff across 8 AAAs and 5 ADRC partner organizations, one of which is the Brain Injury Alliance, and a few others are Centers for Independent Living, or as you all call them here in California, ILCs. And they're claiming for information referral assistance and staff, and also for their person-centered counselors. Those are the types of staff claiming in Nebraska. All right, next slide is Iowa. And Iowa has also, their claiming rate is about 22 to 35%. And they use a methodology that you all tested, which is 100% time tracking. However, versus how you all tried it out was 1 month in a quarter, they're doing it continuously all the time. They also drew down about 2.1 million in fiscal year 2022, and they have 6 AAAs participating, so about 80 people across the state. They're claiming for information referral staff, person-centered counselors, and some care transition coaches. Next slide, please. Next state we have is New York. They put this in place a few years ago as well, using a random moment time tracking methodology, and about 2 million as well in fiscal year 2022. And their staff claiming it's pretty similar to Iowa in terms of that information referral staff, the care transitions, the person-centered counseling. And on the right hand of the side of the slide is the New York Connects logo, which is what they call their no wrong door system, and it has a shape of the state. Next slide, Pete, please. The most recent state to get approved by CMS for this is Hawaii, and they recently got approved just within the last month. And we don't have information on how much they're actually claiming right now, but they had to give some estimates, and they did some time studies, and they were thinking that they would be around 60%, so 61.8. And they also are using a random moment time methodology. And like Nebraska, this is like 2 emails that come at random moments, one at a random moment in the morning and one at a random moment in the afternoon, asking the staff member what they're doing at the moment. And they have a period of time to respond to a survey via email. Next slide, please. I am going to pass it to Kristen for some time tracking scenarios. I just want to check the chat. I don't think I see any questions coming in. So all over to you, Kristen.
All right, thanks, Christina. So as she said, I'm going to go over a few time tracking scenarios that I've pulled from other states' training materials for their ADRC staff. I want to say right up front that every state is different. You know that. These scenarios are just meant to illustrate how CMS has approved many of the activities that you do on a day-to-day basis. They've approved those for Medicaid reimbursement. Each state that has Medicaid administrative claiming for their no wrong door or ADRC system had a plan approved by CMS that defines the activities that can be billed for reimbursement. Ultimately, in California, the activities that ADRCs will be able to claim for will be determined by what goes in that plan and what is approved by CMS. So I just want to kind of put that caveat out there right off the bat. But you go to the next slide. All right, so this first scenario is from Iowa. And as Christina mentioned, they do 100% time tracking. This slide has their activity codes and probably looks somewhat familiar to those of you that participated in the February time study, a lot of similar categories. There are codes for outreach and education, referrals, monitoring and coordination, training, so on. The bolded text on this slide, so codes 1A, 2A, 3A, 4A, 5A, indicate codes that are Medicaid related and can be claimed for that 50% reimbursement. Go to the next slide. So for this scenario, Jack called seeking information on affordable assisted living for himself and his wife. During the phone call, you talked about reasons for considering a move to assisted living, facilities in the area, home-based options, payment options, differences between Medicare and Medicaid, and then also options counseling. So Jack thanked you for the information and said he would think about the options provided. You didn't make any referrals. After that call, you collected the necessary intake information, recorded call topics, and compiled and emailed the information to Jack. Note in this scenario, it does include both the total time and the total recorded time there at the bottom of the table. Iowa rounds to the nearest 15-minute increment for recorded time, so that's why there's that discrepancy between the two numbers. The second table shows how time was coded for each activity and why. So all of this time was coded as Medicaid-related outreach and education. And I believe these slides will be shared, so I won't read through the whole explanation there. But let me go ahead and go to the next slide. I don't see any questions yet in the chat, but feel free to jump in at any point. All right, so in this scenario, still from Iowa, a provider called you to ask about non-medical transportation options for a client. During the phone call, you talked about the client's name, their need for transportation, and then the caller's name and contact information. You collected the necessary intake information, recorded call topics, compiled and emailed transportation information to the provider. So about 15 minutes there. None of these activities would be coded as being Medicaid related. You can see they talked about, non-Medicaid related services. So none of this activity would be claimable. Let's go to the next slide. All right, this scenario is a little meatier, and it does span 2 slides. So starting here on the activities, Jill is trying to determine next steps as her husband's Alzheimer's disease is starting to progress, and she is having difficulty making decisions about ways to help him. So this activity is an actual in-person, in-home visit. So you'll see listed there, she preps for the appointment, she travels to the appointment, or they travel. I think Jill, sorry, is the name of the person that the ADRC staff is visiting. While there, they review and complete the options counseling assessment, discuss caregiver programs, discuss payment options for services, including Medicare, long-term care insurance, and Medicaid. And then person-centered counseling to identify services and develop a plan. They then travel back to the office and complete the documentation. So for all of this, this was 3 hours and 51 minutes when rounded per Iowa's process manual, 3 hours and 45 minutes. So those are all the activities. And so if we go on to the next slide, we can see how we claim them. And if anyone wants to kind of jump back and forth, we're more than happy to do that. So you'll see some stars. There's some stars on the table, and those indicate where there is Medicaid related activity. So the blue stars indicate fully Medicaid related activities, and the red star at the bottom indicates an activity where the time was split between Medicaid and non-Medicaid. So prepping for the appointment, travel to the appointment, the options counseling assessment, and reviewing payment options for services, including Medicaid, are all coded as Medicaid related. Discussing caregiver programs and the person-centered plan that ended up coordinating access to private pay LTSS, and then their travel back to the office are not coded as Medicaid related. There's a little bit of nuance here. So on splitting the travel to and from the in-home visit between codes, this could also have been done the same way as how the documentation was split between the A and B code. But basically, splitting time between Medicaid and non-Medicaid related codes so that you can be as accurate as possible in your claiming. Let me pause. Any questions in the chat or anything else? Okay, I'll keep pushing along. Yeah, we can go ahead and go to the next slide. So we're switching states here. This scenario is from Maryland. They use a random moment survey for their time study. and their activity codes are listed in the table on the slide. So a lot of similar activities. We got outreach and education, application assistance, referral, coordination, monitoring, training. What is a little different here, though, is that for activity code 3, that's the referral, coordination, and monitoring. There's the Medicaid, the non-Medicaid, which we expect, and then at risk of institutionalization and Medicaid spend down. So Maryland is able to claim this time as long as they have documentation on the individual's risk for spend down. They use it's called like a 180 worksheet, I believe, in their state, and Hawaii has a similar code as well. You'll also notice that they have options for not tied to a specific program under some of their codes, and so that'll come up in some of the later scenarios. So this just illustrates how each state does it differently and how CMS has approved different plans. So we'll go ahead and go to the next slides and do a couple of scenarios from Maryland. They set theirs up a little differently, as you can see. So you receive a call from an individual who wants information on where to receive a flu shot. The person tells you they have insurance through Medicaid. So you would code this time as code 3A, referral coordination related to Medicaid. We go to the next slide. That one was pretty straightforward. All right, so you were at the County Senior Expo or some major event working the ADRC table. In Maryland, they use their specific name for their ADRC. You're handing out brochures and explaining services. How would you code this time? So this code would be 1C, the outreach that is not tied to any one specific program, which again, not every state has that code, but that is how it has worked for Maryland. So I just want to pause. I know that was a lot to digest. So on the next slide, we're happy to just kind of talk through any questions, thoughts, other scenarios.
I'm wondering too, I'm scanning, I know I have my list of the places that participated in the time study, but is anyone on that could give a little kind of 30 seconds of how you found your experience to be participating in the time study?
I'm wondering too, Sandra, maybe you could stop sharing slides so we could see everyone, and then raise your hand, or you could unmute, but I think you might need to raise your hand and then we can unmute as well.
That makes us really large on the screen. Well, it is a lot to digest. So I think we're also very happy to, if questions come up later and direct them to the CDA folks, we'd be happy to correspond outside of this meeting time as well.
Thank you, Kristen and Christina. I think with our ADRCs, we are still developing the program, and with your assistance, we look forward to continuing to work with you and maybe making some more presentations in the future as there are more questions as we get to implementing it. It's really exciting. Especially great to see the different states' success and what they've done with it. I'm curious if any of the ADRCs too who haven't participated in the time studies yet, or maybe are thinking about it, if there's any barriers to participating right now that you're thinking of for your own ADRC, and maybe just getting some thoughts from Kristen and Christina, having worked with other states, about how they kind of overcame those barriers.
Yeah, I think that's a great question, Amanda. That would really help us as we're putting together this proposal to CMS to understand sort of like the real world, what's going on. And yeah, so please feel free to share that.
I think I see Ruth has raised her hand. don't know if you can unmute.
This is Ruth. Great to see you guys. I hope you can hear me okay. And so we did participate the last time, but we actually did opt out this time around. A big reasoning for that is that we are participating in CalAIM, which is a Medi-Cal specific, it's a CalOptima program. And so we didn't know how that's going to affect anything, if this is kind of like double dipping. Are we eligible for Medicaid, kind of compensation if we're already getting compensated for Medi-Cal, CalOptima related work that we're doing through CalAIM. And so as far as challenges that we've experienced, the last time there was some accessibility issues. We are an independent living center, so there was some accessibility challenges, but I also know at that time that your team was doing an awesome job on creating accessible, versions and templates that we would be able to use. And so I believe that challenge has been taken care of. But yeah, I think for us, the biggest kind of barrier or concern this time around, as the last time we were not participating in CalAIM, and this time we are. And so we don't really know how that's going to affect anything, if that's considered double dipping. And we know as we're also providing services at the same time, it's just a lot of extra. I think that was a bit challenging to be able to, kind of fill out like a time by increments of time, and just, it's quite a lot. But that's really for us what we've been experiencing, and kind of why we haven't been able to this time around. I think the CalAIM thing kind of threw us off a bit. So yeah, just sharing some thoughts there. Thanks.
Thank you so much, Ruth. Can you share a little bit about what you're doing with CalAIM? Are you doing case management, or what are the activities that you're doing with CalAIM?
Absolutely. So through CalAIM, we're currently contracted to provide 3 different services. One is the housing. One is transitions from a nursing facility to the community. And then our third one is the EAA, the Environmental Accessibility Adaptations, a fancy word for home modifications. And of course, all of those services do, include options counseling, short-term service coordination, transitions, of course, and then and of course, in every service we do, we're always providing information and referral. Like that's just, so kind of those are the basics, but definitely all 4 core services are covered through our CalAIM contracted services as of now.
Mm-hmm. And are you helping people get onto CalAIM too? Like, are you talking to them about CalAIM and helping them get qualified to become eligible?
Yeah, so you know what? There has been actually situations where a consumer fell out of eligibility. Either they forgot to fill out their, recertification paperwork for CalOptima, or they might have, had a change in income, and then now they are no longer qualifying, whatever it might be. In those situations, we have helped. Of course, we don't have access to like the CalOptima member, like we can't make somebody a member, but we can definitely help get them connected to the right places. And we've helped a lot through conference calls. Sometimes consumers are like, we tried calling CalOptima and it's not working. And so conference calls have helped with that a lot. And there's also been situations where a consumer had just moved from like LA County to Orange County. So they're still not showing up in the CalOptima system. From the conference calls that we've made, it sounds like it can take like 30 to 45 days, even after they've submitted all the documentation. It just, takes a minute for the system to process it. So those are the ways that we've helped. And then of course, CHIOC is one of our ADRC subcontracted partners. They specialize in Medi-Cal. And so for individuals that are Medicare recipients, but they're not sure if they would qualify, they're like, dude, I'm on a fixed income. I should qualify for CalOptima. I should be, be able to do Medi-Medi, in which case we'll refer them over to CHIOC to find out, hey, maybe they can help you with a Medi-Cal application to see if you'll qualify. So those are, kind of the different ways that we've helped with Cal Optimum membership, although we're not doing it directly, we're helping them get connected to the right place.
Gotcha. But you're not getting paid for that like pre-eligibility work, like you're just getting paid for those 3 services: housing, transitions, and home mods.
That's kind of the tough thing with CalAIM. Unless they are a Cal Optimum member, we could not charge for, any of our services that were,
Right.
of course, everything's free to the member, but we couldn't charge Cal Optima for any work done prior to us having an active authorization through Cal Optima.
Right.
Yeah.
So this is actually a really great example. I'm really glad you brought this up, Ruth, because if you also participated in Medicaid claiming, you would be able to get reimbursement for that like pre-eligibility work, right? So right now you're only getting paid if the person's like on CalAIM, right? So, and we do have, other states that are claiming are also participating in whether it's like Medicaid waiver case management or managed care, administration. And they're also doing Medicaid claiming. So there are ways to ensure that there's no double dipping is happening, but that to make sure that all the work that you're doing that's Medicaid related, you're getting compensated for. So I'm really glad you brought that example up.
Sure, this is Ruth, and that's really helpful to know too, and something for us to consider as well. And I wonder if we're like receiving, let's say we connect with someone and they have questions about it, but then we connect them to someone else. Is that still billable, even though we're not the ones that's providing the direct actually like providing the actual solution with them, but we're connecting them to another place? Would that still qualify as billable?
Yes, it potentially could. Yep.
Thanks.
Anything else on that, Kristen? I know I jumped in, but you might have thoughts.
No, you covered everything I was thinking.
Okay.
I guess the only other thing I would add is, well, and I know Ruth didn't take part in this most recent time study, but for folks who did, so that CalAIM work would be in the like Medicaid duplication was the name of the code, I believe, in this last time study. So just to note like where that, had they taken part of the side study, like that's where all that CalAIM work, and once you had the authorization and we're working with them on those 3 different activities, that would be coded under the Medicaid duplication to avoid double dipping.
Yeah, and I think it's like one of the things that's hard to wrap your brain around for Medicaid administrative claiming is it's like it's not really set up like the traditional Medicaid, what's in the Medicaid state plan, right? So like what's in the Medicaid state plan, it's like you do this thing and then you get paid for it. But Medicaid administrative claiming is, the definition of it is anything that increases the efficiency or the effectiveness of the Medicaid program. So it's all these sort of like administrative things like helping people get onto Medicaid and like making sure people get connected, but it's if there's not a way to reimburse for that kind of case management. So it's a little bit of a different way of like thinking about it. It's not like a fee for service, but it's more of a reimbursement for the time that you're spending to make Medicaid work better in plain language, I guess. And we know that we all do that. I mean, you all do that, right? Like a lot, just by the virtue of the nature of your business. Yeah, other thoughts or questions?
Those were great questions. I also did want to just add on about the accessibility. So our team is always working to make everything as accessible as possible in all of the ways possible. So if there are ways, in particular for your ADRCs, that you wish to see things even be more accessible, we would love to know. So even just place it into chat as we're wrapping up here. Thanks, Kristen and Christine. I really appreciate it for your time tonight.
Do you want to ask the question about, or do you want us to talk a little bit about the staff, Amanda, who can participate in this?
Sure, that would be great. And then we'll just keeping an eye on the time. We've got maybe 3 or 4 more minutes, and then Allison, we could hand it back to you. Perfect. Great. Thanks. Yeah.
So the other piece that I think is worth chatting about a little bit is that not only the staff that you have at your local ADRC partnerships that are paid for by your ADRC infrastructure grants, but really anyone in your ADRC partnership, I'm going to just say it that way because they look different across the state, as I understand, could participate in this time study. So it's not really like limited to the state funding that you're getting. Anything you would add to that, Amanda?
No, I just think that we've heard before that that might be a barrier. The assumption was it was only grant funded, ADRC infrastructure grant funded, but it's really any state and local funding, right? Just not federal funded positions and people, right? So great to just clarify that for those ADRCs. And we know you also receive other funding from a lot of different sources. So just another thing to consider in participating in the future. Thank you. Yeah. So Sandra, I don't know if you want to start sharing slides again. And Allison, I know we had a little more time to talk about infrastructure grants, maybe even just touch upon it. Allison, you're muted.
Thank you so much, Kristen and Christina, for sharing on Medicaid administrative claiming. Now we have a little bit of time. We'll turn to an open discussion about ADRC infrastructure grants. Next slide.
Sandra, can you share the slides again, maybe? I'm not seeing them here, but either way, you could keep talking, I know.
So as most of you know, the ADRC infrastructure grant funding is intended to support local emerging and designated ADRCs. We hope to develop and sustain the local no wrong door system to enhance consumer navigation and access to long-term services. So we have a few minutes of discussion about the grant, and we would love to hear from you. Since we don't have that much time, maybe we can raise hands. And then if you have any further questions, you can email adrc@aging.ca.gov, and we can certainly answer your questions. So if you're having challenges or obstacles, it's possible other ADRCs are having similar obstacles or challenges, and we'd like to hear from you. Do you have any obstacles you'd like to share, anyone? Please raise your hand. Also, we'd like to hear about the most creative ways your ADRC utilized infrastructure grant fundings. Anyone? I don't want to put anyone on the spot, but one of the, I've heard about Chris McCoy's way of adding kiosks. And Chris, I see you're there. Would you like to share a little bit about the kiosks you've created?
Sure.
Thank you.
We, about 2 years ago, we were trying to figure out how to bridge the technology gap for seniors and disabled. So I found what we call a kiosk. It's from Displays to Go. And if anybody's interested, you can email me and I will get you the information of who to contact to look into those. But it's a really neat kiosk. It's about a 43-inch, I believe, TV screen, basically, mounted onto a pedestal of sorts that can raise and lower to the levels of sitting down to standing up. It can raise to any of those levels in between that. It also can tilt. One of our locations where our kiosk is at has actually started doing puzzles on the kiosk to kind of help the seniors that love to do puzzles get used to that touch screen and technology. But each of the kiosks is preloaded with our online resource directory. That's how we satisfy the enhanced information and assistance piece of our ADRC, is to provide an online resource directory that's available 24/7, 365. So each of the kiosks is loaded with that. and they are generally located in the senior centers. We cover 4 counties under the ADRC: Amador, Calaveras, Mariposa, and Tuolumne. And we have 1 kiosk in Amador at the senior center, 2 kiosks in Calaveras. Both of them, well, one of them's in the one of the libraries, and the other one's going into the other library. And then we have 4 of them in Tuolumne County. We have 1 at my ADRC office, 1 at our Area 12 Agency on Aging office, 1 in Groveland, and that's the one that's doing the puzzles with seniors, and 1 at the local senior center. And then we do have 1 in Mariposa County down in Coulterville at a community center that they have in Coulterville.
Wow, that's great. What a great use of your infrastructure grant monies. It's very helpful. So if anybody has any other creative ways ADRCs have utilized ADR infrastructure grants, please make sure to shoot us an email and let us know about it. Also, as you know, the annual plan is coming up due, and I just want to create a reminder that tomorrow, May 9th, from 1 to 2 p.m., the ADRC Infrastructure Grants Technical Assistance Office Hour is happening. Sarah will put a link in for you to register. And I think we've run out of time. So I want to really thank Kristen and Christina for a wonderful presentation on MAC. Thank you so much, and have a wonderful rest of your day.
You bet. Take care.
Take care. Thank you.
Thank you.